Good afternoon, everybody. So, can we start?
Yes, Miss. Good afternoon, Miss.
So, do you have any doubt in last class? So, today we are going to see the practical aspect of it. Do you have any doubt?
No, Miss.
So, can we go into the practical aspect?
Okay.
Yes, Miss.
So, first, let me explain with the videos that we have taken in our lab. Then later, I will show you some of the other videos that I have taken from the YouTube. Okay, so here it will be clearly explaining where to hold and how to lift do the movement. Okay.
So for the rolling activity, there are two types of rolling. One is log rolling and one is segment rolling. So let's do a log rolling.
So
For
first is log rolling and segment rolling.
let's take a
Okay.
scenario. We have a patient with the left side weakness, right side strong. So in stroke patient, left is weak and right is strong. So to do rolling, in the log rolling, we have to ask the patient to keep a strong leg on the weak leg. Can you please do that? Okay. So usually patient will be doing, if at all patient find difficult, we have to keep it. Okay. Next, keeping the hand. So there are two ways to keep the hand. One is, most of the time it's around 110 degree with the shoulder, and we swing the shoulder to get into the side. Okay. So if at all patient has a problem with the range, most of the time shoulder patient shoulder, then they won't be able to reach this point. So in that case, we can try to we can do some other methods to do it across the chest. And this is actually efficient. In this, there are methods like clasping the hand, non-clasping the hand. So one is clasping the hand and non-clasping the hand. Clasping the hand would be meant for those patients who are one side weakness. So a strong hand, your right hand is strong, carrying the left hand with a strong hand. So then swimming is performed. Imagine it's a paraplegic patient. We don't have one side strong, we don't have one hand strong. In that case, they will just swing the hand this way. It is meant to use the momentum. Next, the second thing is that we have to worry about is the neck. While we are doing the rolling, we have to flex the neck and they have to turn to the side area. Imagine here it's a left side area going to do. We have to do this. Okay? So we're going to do the log rolling. So I'm going to keep your right leg over the left. Your hand will be slightly up. Okay, let's go to the stroke patient. So we're going to clasp this way. While it is going to the moment in the third swing when you're almost going to that side, you have to lift your head down to that side. Okay. So just show you 1, 2, and 3. Legs. Yeah. Correct. This is actually rolling. She has done a complete roll. So
This is log rolling where the complete body will be turned to the other side. Okay. So this is called hand clasping, and this is crossing over the leg. Okay, so depending on the neurological condition which the patient is affected, there may be some modifications which you will be learning it more in deeper when you are learning your neuro.
she did a complete roll. She did a complete roll, but it would be sometimes we don't just get the patient. We always go first for the sideline. Let's say when she did that. Thank you so much. So when she did the swing, neck, we can keep her in sideline. Okay, and try to relax. Bring the shoulder. Okay. In such a way that her first one, so find the sideline. Keep training that for several times till the patient gets independence. Once patient becomes independent, we have to see whether the patient can maintain sideline position. And in sideline position, we have to see how long the patient can spend in sideline. And if they can spend without the help, assistance independently, then we can progress to floor and the next stage of the progression. How to keep the show?
Normally, like for neurological patient, they may not be able to lie down in this position for a long time. You need to keep a pillow or you need to keep some other support behind so that she's not rolling back. Since like this is a normal person, so she is able to maintain in this position.
The shoulder, if it is a stroke patient, the down leg will be the affected one. So we can pull the shoulder slightly forward and then the sleeves. Okay? So why we keep it slightly trapped? The reason is we don't want the whole body weight to directly fall on the shoulder because we'll have shoulder pains and the shoulder will be very painful. That's one reason we don't keep that. Imagine if the patient is normal, we don't have to do that. Normal in terms of they don't have shoulder problem, Parkinson's patient, multiple sclerosis, spinal injury, you don't have to worry about that. Just keep it as it is. But only in hemiplegia, stroke, we have to worry about the shoulder. This is sideline. From here, we can keep training the sideline position. Sometimes, if the patient is able to maintain very good sideline position, we can also give a resistance to check whether they are able to maintain this position. For example, I'm trying to push the patient forward and backward, and I ask Melissa if you have to try to maintain this position without losing it. But I'm trying to balance it. Okay? You have to maintain the position. So I'm getting the resistance, cause and balance, but she's trying to do her best to maintain the position. Okay, this can be done as a part of the training. Okay, that was about log rolling. In the log rolling, we can also use different way of leg position. This another way is, imagine one leg can be flexed. With this kind of, also we do the log rolling. Everything is same like the way we can. With this time, let's not do clasping, we'll do just without a clasp. Okay? So she'll be swinging, sorry. 1, 2, and 3. This is another method. Okay? Another method would be both the knee flexed. This is not used for stroke patient. This can be used for those patients who have some stability in the ankle leg and have a mobility problem. So both the legs are flexed. They should be able to hold on to this position, and then we can do one. If not, if you don't want to swing, sometimes you want to use some other technique also. Yeah. Such as like we ask the patient to bring this arm to the other side, across the chest, and reach for the rail of the bed. Sometimes we are in the bed. We ask them to do a reaching for the rail of the bed. So we have while doing flex and floating. So yeah, as if she's trying to reach for something. Exactly. So that's hand. Okay. So that hand should be spread so that she doesn't fall onto her hand. She doesn't, cause impingement. So this is the correct position. Okay. Listen, I'll just swing the leg and also hand and try to reach across the body. And it will be perfect. So this is different way of log rolling. Okay. Log rolling, and under that we have many categories. Depends on the ability of the patient. Next, we'll go with the segmental rolling. In segmental rolling, we have patient who do one segment at a time. So let's take, we're talking about patient with rolling. So first they will be doing a shoulder roll and then followed by the leg. So 1, 2, and 3. First they'll do shoulder, followed by the bell. Okay, one by one. This is considered to be more difficult than the long roll. So we initially start with the long roll and progress to segment. Okay, so this helps to lengthen the muscles in and around the trunk, stretches the spastic muscle, elongate the spastic muscle. So, and it also helps to facilitate the reflex. Trunk, neck over the trunk reflex helps in this aspect.
Okay, so this is about rolling from supine lying to side lying and log rolling and your segmental rolling. Okay, so let us see one video about rolling.
To show a video for mat activities. Mat activities mainly used for transfer activity of the patient such as hemiplegic, paraplegic and other neurological conditions. The uses of mat activities are first to make the patient independent, second to teach them the transfer activity from low stool or low mat to that of high or high bed in their home, third to increase the balance, and fourth mainly to take a patient position for each and every activity that we teach in the physiotherapy. The mat size should be mainly of 1800 into 1740 centimeters. Now we are going to show a video that includes the mat activities such as rolling, then from quadruped position, taking from various positions such as high sitting, then into kneeling, half kneeling positions for the patient of hemiplegia. We have considered left side of the patient as affected. So here we are going to show various videos which shows the positions to take by the therapist or to teach the patient for the transfer. Now this is a video for rolling activity from side lying to prone position. Here the scapular position will be in abduction and depression, making the patient to hold the mat, and the trunk will go in flexion. Here the patient now rolls from side lying to prone position. Now the patient will be from side lying to supine position. Here the scapular movement will be adduction and
Okay, and the second
elevation, and the patient holds the mat, and now trunk will go in extension. Thus the patient will now roll from side lying to supine position. This video shows the activity of rolling from supine to prone position.
okay, okay.
Here
ஆனா இப்போ
the therapist
இப்போ
assists
இன்னைக்கு
the
அனுப்புனது எல்லாமே
patient
பழைய
to
லிஸ்ட்
move his
தான்.
head in flexion and rotation, hand in flexion and adduction, his leg in flexion and adduction, and the patient thrust as well the therapist help to roll from
Okay.
supine to prone position.
நம்ம ஒட்டுக்கா கலெக்ட் பண்ணிட்டு அப்புறம்
This is another video showing the rolling activity for the
எல்லாரும்
patient
சொன்னதுக்கு
from
அப்புறம்
supine to
full-ஆ
prone
collect
position. Here, the therapist assists to turn the head of the patient in flexion and rotation, his hand in extension and adduction, and his leg in abduction and extension. The patient thrusts as well the therapist assists to move the patient from supine to prone position. In this video, the patient is taught to roll from prone to supine. Here, the therapist assists patient's hand in flexion and abduction, his leg in extension and abduction. Now, the patient thrusts and the therapist assists to roll from prone to supine position.
Okay, so this is about rolling. So I hope any doubt in this rolling? Do you want to see one more video or you are clear? Okay, so I will show you one more video then. This is what like facilitating each segment, like each movement. So first head and neck you have to facilitate, then upper limb you have to facilitate, then lower limb you have to facilitate. Okay, any doubt so far? In rolling, any doubt you have in rolling? So if no, I assume that you don't have doubt. Are you all there?
Yes, Miss.
Okay, so we will go to the next now.
Supine to sideline. From sideline, you can take the patient to prone, or we can take supine directly to prone. Okay. So what we can do is imagine we are taking from supine to prone. So can you just do log rolling? Okay. As she knows how to do log rolling, let's do it. So 1, 2, and 3. Neck tension. Perfect. Okay. When she gets into this, no, just relax. Imagine she's in this position. Okay? So my job is to bring her shoulder up so that she clears this and relax. Now you relax to the bed. Go down to the bed. Turn to one side. Okay. So one more time you do. We'll do this one more time. So just come back to the supine. Yes. Come back to the supine. Yes, sir. One leg on the other. 1, 2. While doing that, leg flexion. 1, and 3. So when she does that, the job is to make sure her shoulder is away from the attachment. That's it. Can you turn to one of the side? Okay. When we brought her to prone position, from here, we can get her from the back to spine position. How do we do
Whatever
that?
happened,
The hand
happened.
is like this.
எனக்கு நீ நோட்டிஃபிகேஷன் போட்டிருந்தா விஷ் பண்ணிட்டேன் நீ நோட்டிஃபிகேஷன் போடல அப்புறம் எல்லாம் ஞாபகம் வச்சுப்பாங்க.
அப்படி பார்த்தா
And to lift your leg
அதுக்கப்புறம் ஒரு நாள்
up in such a way that she brings her pelvic and scapula backward. Okay? While doing, you will imagine you are on the right side. You turn to the right side, extend your leg. Okay? So the patient, to do from prone to supine, it's important to have the spine strength and neck strength. Okay? So neck extension. extensor and spine extensor is very important, and it is most difficult task to do. It's not possible to achieve this at the early stage of rehabilitation. Okay? So sometimes we don't go from home to supine all the time. We finish supine sideline, then we do bridging and many other activities. Maybe later on we come back to this because it really needs a lot of muscle strength, core muscle strength, etc. So let's just give it a try. So what you have to do, similar leg supine, you have to bring your hand back along with your leg backward. Okay. So we'll do swing if you want, or just directly as if you're reaching backward. Imagine I have an object that I'm going to give you. You're trying to reach backward from your hand and from your leg. Can you do that? Reach from your hand towards me. Try. Yeah. Okay. I know it's difficult. It's very difficult. Let me give it a try. Let me give it a try. Can you come here? So if I'm the patient, the therapist will be standing. No, I'll be like doing this. Obviously, therapist will hold here and on the chest. Something like this. Then I can come back to sideline. From sideline, I can train the patient. Then come back to sideline. Maybe that could be the possible. So one more time. We'll do that. So if you want to train from prone to supine, you can bring the patient to the edge of other edge of the bed. Then you put more here. They have to push actually the patient so that they have more surface to roll on. One more time. Imagine this patient needs assistance. So what I'm going to do is hold my hand one here, one here. If they need assistance, if they don't need assistance, we'll ask you by themselves. I'm giving my assistance. So 1, 2, and 3. Okay. So this is spine prone to supine. So here, what else I can say? Okay, good. Next, we'll go for from supine to prone position. So imagine we do rolling. So we do rolling 1, 2, and 3. Okay. Then we can, if you want to start from prone to prone elbow, we can slightly put the hand and I can keep my leg this way and I bring or we can. If this can be done after prone to prone elbow rather than prone to supine rolling, we can continue with that. This way. Thank you.
The last one you saw was like bringing the patient from prone to prone on elbows. Okay, so we will continue with next. One minute. It is getting downloaded. Okay.
Okay, so as you know, in the rolling technique, we did supine to prone. Patient will be in the prone, so hand will be, you can keep the hand at the side, or sometimes they might be slightly deep. You can keep it elevated. They might be in this position. So what's your job is from this position, you have to get the patient on prone on elbow. So we will tell the patient, so we, Mr. Mahesh, so come here and want you to support on elbow and come upright position. So try to lift your head and bring your shoulder blade up. So now here the patient is quite strong, so he did it by himself. So he didn't need my assistance. Imagine, let's go back, and I want you to support only very less, and I want to do very good job. So my leg is like this, it's a perfect position. My hand will go slightly at the anterior area of the chest, like around maybe clavicle or the strip. Now I'll ask the patient to lift the head and slightly bring your hand inward. So this is not as easy as it looks. Might be a little difficult for the patient to lift half of the body weight. So, but this is exactly the way that we do. Okay, sometimes.
Okay, sometimes what will happen, the patient might have more weakness in the upper limb. So for example, patients with hemiplegia and other, so they might have weakness in one side of upper limb and lower limb. So for those patients, you need furthermore assistance to bring this hand. Now if you see like she did not support the hand, she just supported the shoulder, and the model himself has brought the hands behind like this. But in case if the patient needs support for bringing the hand also, then what you have to do is, with one hand you have to hold the complete shoulder. That means with the imagine this side is weakened, so that means like you have to bring the hand and support the complete shoulder with one hand. So you have to put this hand below, like under the chest, and hold the complete chest, and this hand will be free to move. So once you are lifting the chest, automatically with this hand you have to pull back the elbow and bring the elbow to this particular position. Is it clear?
The patient come to this position, but they won't be able to maintain. That means the moment I leave the hand, they just swing and fall onto one side, or they just collapse. So it's once you bring it to this position. So this is a transition period from one position to other position you brought. So what you have to do is you have to train this on and off. So again, you ask the patient to stretch the hand outside and go back to the prone position. So this way. Again, you have to bring the patient to the prone elbow. So you keep doing this until the patient gets a control or able to do almost independently from prone to prone elbow. Once the patient does this, next challenge is to maintain. As I said, next challenge is any position you acquire static stability, a static control. So can he maintain this position for a long time? How long? So initially, if you want to check whether they are doing able to maintain, 30 seconds is the time that you at least have to allow the patient to be in that position. So what I'll do is I'll remove one hand, remove the other hand, one hand, and let's just check. So I'm getting confident that the patient is putting an effort and trying to maintain. So I'll wait. It might take a few days for me to really get this control, because I have to keep working on this. Imagine there'll be a day that he able to, with the training, he able to maintain more than 30 seconds. Okay, he got at least the basic static stability. He's able to maintain for a short period of time. Once he does this, maybe he can hold hand, little face to something, relaxed finger. This will be a little more easy for the patient. Once he gets this, I can increase the time period in this position. Can go from 30 seconds to 40 seconds, 50 seconds to 1 minute to more. So maybe a maximum of the 2 minutes would be enough. After that, they might get tired. So imagine they got good control, static. Next is mobility. Mobility means they have to start. First thing in the mobility, they have to shift the body weight. Shift. Yeah. Slide, shift, slide, shift. So you have to disturb the basic support here. So once they start shifting, this is the first challenge in mobility control. You can call this as dynamic balance. more or less the same. Once they develop this, so then slowly you can think of lifting one hand slightly and then bringing back. Okay? Lifting slightly, lifting slightly. Okay? Okay, so we have to keep repeating until they are able to really put all the weight on one side of the hand and able to shift the weight. They get more control or symmetrically on the limbs. So what you can think of this is, when you are doing in this position, you can see shoulder and elbow, it should be exactly at the same line actually. Okay, that's for initial. Once they get a good control, you can keep the elbow far away because then they are able to control more like that. But initially it has to be exactly here this way so that they use center of gravity, that is axis which pass through all the joint. It's easy for them to maintain this position. So that's done. So what are the other challenges we can give? Once I know that the patient is able to do this, I can ask the patient, can you touch my finger from the left side? Very good. Left side. So it's just within the base of support. If you want to do away from the base of support, I can be far away reaching at him. Can you? So he has to slightly move, change the base of support. Just reach. So multi-direction you can do. Can you touch me? Can you touch me? Okay. Can you touch me? No. From the right hand. Can you touch on that? Very good. Very good. Keep it here, and we can ask him to squeeze this ball together. Can you squeeze this ball from your elbow? From your forearm? You know this, yeah, something like this. So you are reducing, you can reduce the base of support. Good. Okay. So I just do. So he can increase the base of support and decrease the base of support. Can you? Yeah. And then wider base of support, smaller base of support. Smaller. Very good. So the less is the base, smaller base of support, you can, in the small base of support, you can do a lot of that. Okay. Okay. That's after this. There is one more thing that you can do in this position is push-ups. I think you all know what is push-ups, right? So he can do elbow push-ups by retracting the scapula. Exactly. There should not be much movement on the spine. Can you look straight? Okay. It's more on serratus anterior strengthening. This can be done as a part of the rehabilitation. This will be the last part. With this, we're going to go for prone on hand. So next challenge will be prone on hand. So from here you can go to the prone on hand this way. So can we go back?
Okay. So here the main thing is we need to bring the person to that particular position. Then like make them to do the particular position independently. Then slowly we need to give activities and improve on the particular position. Okay, so first bring to the position, then bring to that particular position without assistance, then let them do some activities in that particular position. So once they do activities on that particular position, then they will be able to go for the next step. So this MAT activities, it is not going to happen in a single day. So each step by step, it will be happening for a long time. Okay, it is a long term treatment only. So next one. Just a moment. Okay, so this two position is if the patient is independent, if the patient has improved and they have become independent, then you will be able to do like this. Otherwise, you need to do like Miss Kavita's one, whichever I have showed you the previous video. Okay, so the next one is
Position and knee bend. Okay, so imagine patients completely supine. They have no control because it's not possible for them to develop strength of the
this
legs.
is bridging.
The stroke
Okay.
patient. Imagine the right side, left side is a stroke. They will not be able to bending activity because they need hamstring muscle to do their job, quadricep muscle. They won't be able to. Maybe in this case, they'll be having one good leg, one bad leg. So with good leg, they can do the bending. How about the bad leg? They won't be able to do. So we can help them. Depends on how much strength they have. So you can ask them to get to the hook line position. So you have to train this itself as a mat activity because once you cannot start from here until unless they get a good control over bending paths, bringing independently into this position. They have to get, otherwise you passively do, how much is going to help the patient? You want the patient to do independently. So you have to keep repeating this activity. Bend until they get the hook position or hook line position by themselves. If not complete, at least they should be having some 60 to 70% like minimal assistance. They should be able to bring the patient themselves into the hook line. Next challenge. Once that is a transition, so we have to keep doing this until they get a mastery in that. Next is, can they maintain this position? Because considering this is a weak, see, this is exactly what happens with the stroke patient. They will not be able to take this. Okay, our job is to do a static stability in this position. So they have to maintain this position for a particular time, like we did it in earlier positions. So how do you do that? You can hold like this and ask them to tuck it. Like I have asked them to squeeze both the knee, and with that they will be able to control it with the help of the other leg or adductor. Okay. Later on, then you can just keep a space between the thigh and ask them to control. So they have to press the leg. They have to give a pressure towards the bed so they maintain it, but not lifting exactly. But they just give a pressure. So this is a
Just a minute, it is getting downloaded.
try to maintain this position. So imagine this takes some time, and then eventually they develop the ability to maintain. Okay, they maintain this. Now you can start with the mobility. So for mobility, you can, after this going side to side, as you know, dynamic stability, first we start the weight shifting. This will be the weight shift. So we have to see whether they do controlled weight shifting. Are they doing excessive? So we have to have our hand to control by them. Just cannot leave, otherwise it just collapses. Okay. So once they do the weight shifting, so if this leg is strong, then we can do only the bad leg weight shifting. This out and out several times until they get a good control. Imagine they got a good control, they're able to maintain well, and so when they're doing the swinging, we assume that there's a lower trunk rotation happening. Okay, so when there's a lower trunk rotation happening, how we can help the patient? One is dynamic control over the leg. Secondly, because the lower spine is moving, if the patient has spasticity, tightness in the muscles, this will help to lengthen the muscle. It's actually, this is the one position that I mostly tell the patient severe acute low back pain to do at home, because when they do this momentum, oscillating movement, it can actually relax the back muscles. So this is really, really good for the first 2 days to over this kind of activity. Okay, but we are talking about more of neuro conditions. The mat is more for neuro condition than so if that is the case, it's going to break this spasticity and lengthen the muscles. When they do this, side from here gets lengthened. When they do this, slightly gets lengthened here. So that's advantage. Once they are done with this, we can, if you think you want to proceed from here, you can go for the next stage is called a bridging. Bridging is where you keep moving. There you ask the patient to lift the pelvic up. This is actually bridging. Again, it's a challenging for a patient who doesn't have good strength in their lower leg. It's not so easy because you need to use maximus and hamstring to do this job. To some extent, back exercise. So, how do we proceed? Initially, definitely we need to help the patient. So, I can just help her while she's doing this. Come on. This is an assistance. Okay? But we cannot give full assistance because at one point they have to do right do themselves, because that will help them to shift them, especially if they want to do bed mobility, or when they want to change the mat, bed sheets, they want to use a bed commodes like bed pan or something. This is the very important thing that we have to achieve at the earliest, otherwise they'll develop a bed soon. So we want them to do rather than me doing all the time. So imagine initially we do assist, but later on we ask them to try as much as possible with the accessory trick movement they might do is hyperextension of the back, which we do. We want the gluteus to be lifted, not the hyperextension. If they do, they are taking the back muscles to do this. So we need to be very careful, vigilant about that. The next part that we have to be careful is, well, not careful, like as a progression, the hand placement. Initially we keep it wider. It's a wider basic support. Then as they progress doing the bridging, they can keep the hand more close to the body eventually, and if the last progression will be crossing their chest. Yeah. With this they do bridging, more challenging. So you have to be thinking about hand placement, how to progress that, and how maximum independently they can do themselves the bridging. Imagine patient achieved at the end of the day independently bridging it. Okay, she did it. Now from here what else to do? Okay, next I can apply resistance to even advanced strengthening. You can apply resistance with the exercise to prevent that, and she gets more stronger with that. That can be done. So okay, initially when we start a bridging, there is a chance when they do bridging, they just pull up, they slide the leg so they don't get a control over it. How do you deal with that? Sometimes, actually, it's not advisable, but you can just keep slightly tight, not put a weight, just hold on so that there's slight stability. or you can hold the hand, or you can put a, this will help them to kind of little assistance because you're locking this, or else you can put a weight cuff so that they get more stability in the beginning, but not weight at all. Okay. So this is called bridging. So there are scooting activity the patient can do. One is scooting up, scooting down, scooting to the side. Okay. This is within the bed they can move themselves. So they don't develop a bed sore, and they can do a lot of bed mobility and make themselves a little bit mobile. So how do we do a bed mobility? Scooting upward. So if they want to scoot upward, so we keep the leg close. We ask the patient to keep compass in the center of the bed. Exactly what she's doing is the one which we are doing anyway. So if you're doing scooting upward direction, keep the knee close as possible to the as close as possible to the buttock, elbow, something like pushing like this. So what she will do, and slightly flexion of the neck. So she will at a time she will push from the leg, from the hand, and she will exactly. Once she do that, exactly. That's all. So now small movement. Now you want to bring the patient down. Keep the leg far away, like this actually. Okay, so imagine the leg goes like this. If you want to bring them down, you need a place to move their buttocks. So it has to be slightly away, slightly. Same, elbow, pressing down. So she has to do the depression, scapular depression, and small bridging. Exactly she's doing. You understanding? She does a small bridging, brings her buttock down. With the shoulder, she does a depression, presses the elbow, brings down, up, and slightly neck flexion. So very small. You cannot do a big movement, so it's a small movement that she can do. With that patient, you can shift, like imagine the bed pillow is somewhere, they want to get into the pillow. You can shift themselves without much help. Initially, we do help, like we help with this support, we do support at the ankle. Later on, they do independent. But the same thing, you have to do side scooting. Everything is same. First, they will do the buttock lift and keep it at the side. Then elbow, push, exactly. That's all.
Okay. So these are the activities you will be able to make them to do in crook lying position. So first, make them to maintain the crook lying position. Then help them to do the pelvic bridging with assistance. Then slowly you make them to do without any assistance. Then start this scooting downward, upward movement and sideward movement. So these activities will help them to improve the lower limb, upper limb as well as the pelvic muscles. Okay, so let me show you one more video how to support this pelvic bridging. 1 minute. So in this, if you see,
October 29th.
okay, so this is not exactly the pelvic bridging alone. They have added some more exercises, but I wanted to show you the pelvic bridging exercises alone. So let me just.
Sure. And on a stroke, almost always one side.
You know, usually the blood clot or the blood bleed, occurred on this side, and we have weakness on this
Sure.
side. All right, so I'm laying down.
Flat on my back. And one of the first things you want to do is, a lot of people have spasticity or tone and tightness, and they also have weakness. So this helps break up the tone.
And tone is one of those things, I always had a hard time really getting understanding for that until I started working with people. But like you mentioned, it's tightness, the muscles have a tendency to tighten up, and they have certain patterns that they tighten up with a stroke. And that's the key, is to do an exercise that tries to break that pattern of tightness.
Even from the beginning, when you still, if you don't even have the tone, you want to start doing, this is a very simple one, any flop over like this.
Yes, exactly.
And that's where you might need somebody to help.
This is what will happen whenever you try to make a person to do a pelvic bridging in neurological person. The leg will be falling down without control. Okay?
Yep, guide you to start. And you're just going to rotate back and forth this way. Now this breaks up the tone in the trunk, but it's also making your leg work this way and this way. So you're starting to strengthen some of the muscles that need some strengthening. And you can actually go a little bit further down, or you go a little further up. And if you get to the point where you actually can do it, without support of the other one, you can do a little bit of this.
Sure. And if you're real weak, you may have a family member, like on the bed, this is what therapists do, this is a real common pivot position.
Yeah.
And they may start like this, holding the knees together so that one might want to flop out.
Yeah, and then you can even put a little resistance.
Sure, okay,
And if I
push, so he's pushing that, I'm
Yeah.
resisting, we go the other way, and then as he gets stronger, then you go to that independent mode.
Right, and then we go right into the next exercise, which is doing a little bridging.
Sure.
And this helps bring the pelvis forward, which with a lot of stroke patients, the pelvis wants to stay back.
Right.
So this starts working on
Up
trunk
there.
muscles and getting a little bit of work on the knee and hip extensors.
You bet.
And this is another one, you can have someone hold the leg
Yep.
like that, hold it
Here,
down,
whatever needs.
and then I can push up like this and start that with a little assist.
So you can see here, you need to hold the feet if it is falling down. Okay, so you need to hold the feet, and with your help of the hand, you need to bring the patient to, you have to pull the knees down so that the hip is going for flexion, or the pelvis is going up. Okay, so with this hand, you can see here, with this hand, he will be pulling the leg down, or pulling the knee down, so that the pelvis will go up.
And I oftentimes, you'll find if you kind of sit on those feet, and I'll go ahead and I'm gonna pull back on the
Yeah.
knees, and that's right here, I'm pulling back and pushing in the knees, that helps a little bit too. And as the person gets stronger, if they don't need you, you definitely don't wanna help if they can do it independently.
Okay. So once the patient is able to do this, then what you can do is you can ask the person to do in single leg. That means one leg the person can raise up, that is extend and raise up like a SLR. Then with the other leg bend, he is supposed to do the pelvic bridging. So this is the progression. It is called resisted progression. Then otherwise you can also keep some weight over the pelvis, so the patient is able to do with the weight. Is that clear? So far we have completed from supine lying, prone lying, then prone on elbows, then prone on hands. Now we have completed the crook lying position also. So before going into the next thing, I think we will have some 5 to 10 minutes break. So the time is 3 o'clock now. We will meet again by 3:10. Is that clear?
Yes, Miss. Yes, Miss.
Students, can we start?
Yes, Miss.
Okay. Okay, so let me show you one patient related video so that you understand how difficult this will be. Okay, so this is a patient. One minute. This is a patient who has spinal cord injury and he will not be able to do any movement in the lower limbs.
Hey, John. Hi, Denver. We're just gonna get right into this. Today you're here to practice rolling. All right, since this is the first session, our only goal is to get you from laying here on your back up onto your elbows on your stomach, okay? All right, so we're gonna start with reaching your arms all the way to the left and then reaching them all the way to the right. And with that, I want you to pick your head up and move with your arms, okay? I'm going to help you here with my own hands, starting that. It's important to keep your elbows rotated in while we're doing this, okay? Because that'll help keep your arms straight. So the first thing is here. We're going to go this way. Make sure you pick your head up. And with your hands, we're going to fling back over to the left, all right? So this is all we're doing. So here, get up and follow your arms. Back, and again, and back, and again. All right, and up. You're getting really good head motion. I like the way you're building momentum. Let's go back again. Forward. Now from this position, it's really important that you reach your arm out toward that wall as much as you can with your head and your arm. So everything headed that direction. Try to visualize headed that direction, okay? All right, so we're going to come back here, and I'm going to help you from behind, and you're just going to reach and try to hit my hand. All right, and back, and my hand. And again, and my hand. Make sure that you keep these arms rotated with your elbows in, okay? And back. Hit my hand. All right, we're going to try to put it all together. Okay. So, all the way back. Now, arms to the left, and we'll swing a couple times just to build momentum. Keep your head up, and roll. Reach, 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 reach. Good. All right. Session 2. The next part, we're going to work on getting up onto your elbows. So you can use your posterior deltoid a little bit to try to pull this elbow close underneath you. And we're going to use some of the same techniques we did to develop momentum and roll up onto that elbow, okay? All right, so we're going to rock back, forward, and back, forward. Keep reaching, keep reaching, keep reaching. All right, and I'm going to help you now. On your elbows, very good. I'm going to climb up here with you. And the next thing we want to do is practice rocking back and forth and getting up high on your elbows and walking them inch by inch back to your knees, okay? All right. Keep walking them to your knees. All right. Now that we're back here, I'm going to have you take this right arm and wrap it underneath your knee and tilt your wrist up like this, knuckles up, to hold on to that knee, okay? So that's what we're going to do. I'll help you here a little bit. Get a good grip. Now we'll come back to both elbows. And you really got to fling your arm over there and push up with this arm, okay? 1, 2, 3. Good. Hook under there deep. All right, we don't want to lose that. All right, the next part of this is going to be rocking off of this elbow up to your bottom, so your bottom is on the floor. Going to use your head again to develop momentum. Try to push up with your elbow toward your legs. So you're going to push with this elbow and you're going to pull with this arm while you're rocking your head, okay?
Okay.
And I'm going to give you help right here at your hip. So rock. This is just where we're going to be, rocking for a little bit. All right, swing that head. Let's try to have your elbow already started in an externally rotated position. I'm going to slide you myself over this way a little bit, just so we don't run out of table. All right? Can you help me and push? Good. All right, now, I'm going to rotate this back as far as you can. All right, let's get this elbow underneath you more. Okay. Can you reach that elbow forward for me, toward the wall? Okay. All right, how's that feel?
Feels good.
Good. All right, so arm rotated out as far as you can. Same motion, we're rocking. We're rocking, get that ear all the way to the left. And 1, 2, 3. Turn this elbow out. There you go. There you go. Now, rock some more. Keep scooting it in. Scoot it behind you. A little more. All right, and this one, same thing, behind you. Externally rotated. All right, now look up. Whew. Seated position. Very good, John.
Okay, so this is how a spinal cord injury patient who will not be able to move his limbs will be able to do it. Okay, just a moment. Once again, just stay on the line, 1 minute. Oh, okay, I'm sorry. Next is, you will see the next video. So once the patient is able to do the movement in the lying, so what is the next thing we are going to do it? So next thing is we will be taking the patient to be in kneeling. Then slowly we will be trying to improve the patient in kneeling. Okay. So now 1 minute. Okay. Okay, this is another video on the patient itself. Then we will go to the next.
And one common way to do this is to utilize the roll first. So you would roll over, get prone on elbows, and then use a technique to come back and end up supine on elbows. So the first idea is, the first challenge here is to roll.
Who is not able
so if you roll over
to
to your
his
left.
leg. So this is a typical patient. It is not a model. This is a
And if you
patient.
could actually get up and put weight on both your elbows. This whole idea here takes a lot of work, takes a lot of strength that you can bear weight through both shoulders like this. And now what Kurt is going to do, he's going to bear all weight on his right shoulder and slowly bring his left arm around and touch down on his left shoulder. And if we could just repeat that again, I want you to really concentrate on his right glenohumeral joint. It really acts as a pivot point through all of this. Now slowly come around and touch down on the left. I want to repeat that again. And it's important when you learn these, when you work on these activities, to break up these activities in their fundamental components. If you have an hour-long therapy session, set certain goals for yourself and just key it on certain components of this. And this component right here is trying to use the right glenohumeral joint as the pivot point and rotating your whole trunk around it. Now come back to me. And you can certainly resist this or assist this depending on what needs the person has. Okay, so now when we've accomplished the first important milestone to come to sitting is getting supine and elbows. He makes this look a lot easier than it really is when you first start. But at first, you have to learn to rock side by side. And this requires loose glenohumeral joints and enough control to hang over one shoulder and unload one shoulder. Right? So now, if I let go of him, he can have all his weight just on his left upper extremity. And once you learn this, then the idea is to throw this arm back as far as you can. Notice the range of motion that this takes as well. Also in the biceps, because it's stretched across both elbow and shoulder. Now you've got to bring your body weight over the right shoulder and momentarily hang on that position and throw your left arm back and then walk up from there. Now, this activity requires a lot of range of motion in the shoulders. The second activity, the second way to come to sitting, if you can go back to supine and elbows for me, please, is a little bit different. This method, Kurt's going to kind of do a semi-roll over to his right, pivoting on his right elbow and touching down with his left elbow. And he's just going to kind of walk around in a semicircle. The disadvantage of this technique, sometimes it puts a lot of wear and tear on the elbows. And when Kurt gets to about this position, the next idea is he's either going to use his elbow flexors or wrist extensors on his left, and he's going to extend this right elbow by using these more proximal musculature. Remember, he does not have any triceps here doing this. And this is an excellent example of using proximal musculature to extend this elbow joint as long as this distal segment is fixed. But if we just reverse that, if you don't mind, go back to about right here. So notice that he's actually attacking this from bilaterally. He's using elbow flexors, right, to bring his trunk in this position because he's actually hooking his distal forearm against his relatively immobile right leg. But the key idea here is that he's able to extend this elbow. And he's really going to do it by strong contraction of his anterior deltoid and clavicular head of the pectoralis major. And why don't you kind of do that as slow motion as you can, but right here. Can you back that up just a little bit? Good. And then come in again, up. And this shows an excellent example here of the anterior deltoid controlling the flexion and extension of this joint. Eccentric activity flexes it, concentric activity, the anterior deltoid extends it. And how about one more? And then come all the way up to sitting from there. Excellent. Good. Angela's going to
So
show.
this is what from supine lying coming to long sitting. Okay, so can you see how much difficult for a patient to come to that particular position? So this is not going to happen in a single day. We need to keep on giving them practice, and the single movement is broken into different steps, and you can make them to do and bring out the movement. So once you have bring out the movement, then you add on the activity. So adding on your activity is up to you. So you can add the activities. The main purpose is to balance them in that particular position. Okay, so with that you can just keep adding any number of activities or any kind of activities. Okay.
There are several ways that she's learned how to come up to sitting from lying down.
This is another
supine.
patient.
Give us some
Okay,
perspective.
so 4 years
how long
post injury
this
of
took you to learn
cervical
this, or how
C7.
valuable is
Okay,
it?
7th cervical rib.
I would say this, again, took me between 3 and 4, maybe even 5 months. It's very valuable. It's an important step to being able to transfer independently. And it's also important for being able to dress yourself. A lot of people, including myself, start with adaptive devices such as rails on hospital beds or bed loops. But as time goes on, you want to be able to do it just with no adaptive devices at all, because it's hard to have to depend on stuff.
And once you own it, then no one can take it from you, right?
Yeah. Yeah, so I can go from laying to sitting, whether I'm in a bed with rails, whether I'm on the floor, whether I'm on a mat. So then it just doesn't matter anymore.
Can you go back and do that again and leave that right elbow all the way straight? Like all the way straight. Just throw it behind you like you did. But leave it all the way straight. Now hang over that shoulder. This is the way someone without triceps often would do this activity. But Angela has a triceps, so she doesn't really have to worry about staying in hyperextension in the elbows. Great. So that's one method that's often used. Another method, again, starts supine and requires a roll. In this case, you roll, and instead of getting prone on elbows and coming back on supine elbows, you tend to just kind of walk your elbows around and keep both elbows on one side of the body and kind of walk in a long arc to come to sitting. I think this can be best demonstrated by Angela. And again, it requires that initial roll, which rolling is a prerequisite to coming to sitting, and coming to sitting is a prerequisite for transferring. So this technique often works well when you don't have the range of motion needing in your shoulders, the hyperextension. It takes a little bit longer, and earlier on it can be rough on the elbows. And you can certainly notice that Angela has very, very loose hamstrings, which does not at all interfere with this activity. Good. Reach. Good. Okay. What if we stop right about there? This is always a hard part, isn't it? Because you have all the weight on your left shoulder. And if we go back to the mat again, now lift up. This is really an abduction motion of the shoulder from here back against all the weight of our upper trunk, and lift up. So this activity itself is very, very important. So you can actually start an activity like this and break it up into its functional components. We need to bear weight over a stable shoulder, and we need to be able to abduct the shoulder against all body weight. About to pull down a little bit. You all right? Yeah. Come up. Okay, you hold there and don't let me pull you down. Hold. Don't let me push you. Hold. Okay. Now, again, hold your trunk real stable. Hold. Hold. I'm trying to establish stability about this glenohumeral joint. Okay, how about if we keep going now like you're going to sit up? Good. Good. And how about right from there, if you would just kind of come back and let's just back up with that task. Just kind of put both elbows onto the mat and kind of walk backwards, just kind of reverse time with that activity. It's kind of like walking on elbows. That's it. Good. And now let's go to your right again. Kind of unload one and load the other. Good. And let's go back. That's it. Beautiful. Okay. And why don't you kind of take it from here? Good. How about this last little part of that maneuver? You do a really good job with that. How about if we bend again? Okay, this idea of getting this maneuver right here is driven really by triceps, but at first that can be weak, and this activity can be actually performed even without triceps as long as you have a well-developed anterior deltoid. But good. And kind of lead with your chin as you're looking to your right. That's it. I'm going to give you some reason.
Okay, so this is about the cervical patients. So next, we will see some video how to come to prone on elbows.
Let's go on
prone on
Okay,
elbows.
so as you know, in the
1 minute. From prone on elbows to prone on hands and how to make them to come to kneeling. One minute.
from the long sitting. The other way of doing. So can I show?
So this is from supine lying to forward push. Did you see it? Okay, so here they have shown it very fast. Let us like see another video where they will show you where to place your hands and other things. Okay.
We're going to go for quadruped position. How to bring the patient to quadruped position? Imagine you can do from prone elbow to prone hand to quadruped. Okay, that's one technique. So how are we going to do this here? I'll be behind here. Ask the patient to be on prone hand, and then slightly lift the hip and walk backward, exactly the way she did. She walked backward, I lifted her hand and she just kept. This is a getting into forward position. Okay, now go back. We will do from the long sitting. The other way of doing. So can I show Shankari?
So this is from quadrupone position, from prone on elbow to quadrupone position. Okay, so now another method is also there.
So another way of doing is getting into quadrupone is imagine the parapenetration, or if you achieve the sitting first, imagine you achieve the long sitting first. From here, if you want to go for quadrupone, you can. How do they do? Go for side sitting, something like this. So from side sitting, then they shift their body completely from this to this, while the therapist will be helping you. So you can bring from long sitting to quadruped or from prone hand to quadruped. But preferably long.
So basically, in case if the patient doesn't have both the lower limbs or both the lower limbs are affected because of spinal cord injury, then you have to bring the patient from quadruped from long sitting. Okay, like how we saw the previous videos of the patients and other thing. So from supine lying, you have to bring the patient to long sitting. So from long sitting, you have to go to quadrupone, like how Ms. Kavita showed you just now. If the patient is having a hemiplegia, then you can go from prone on elbows to prone on hands, then to quadrupone position. Is that clear? Because in the prone position, yeah, they will have little bit of lower limb control. So it will be easy for you to support. So that's why you can bring like that manner.
Prone hand to quadruped position.
So once the patient has achieved this quadruped position, then you can start activities like this.
Sometimes, again, as I mentioned, we have to keep practicing prone hand or elbow to quadruped. They keep doing it until they get the independently they can do that. Once they do that, we have to maintain that position. So sometimes we use this one, like, as I showed, something like this. It's very big actually, but we use the ball underneath the abdomen to maintain the quadruped. This is quite big for her. We don't have a small, so we cannot use this, but we can use that in quadruped. So imagine this ball will be under her abdomen. So she'll be supporting on the ball so that she maintains the quadruped position for long time. So depending on the ball. But eventually what we want, we take out the ball. We want her to maintain independently. So we see how much time she spends. What are the problems you might get? If you're dealing with a stroke patient, the other time we were like, okay, let's take this right side is weak. What can happen? She'll collapse. Exactly. She does this. Okay. So it's important to get a good strengthening of triceps before we get into this position. Or imagine you want to do it very early and as a part of rehabilitation, you can put a splint. We can have a splint, elbow splint that can support the elbow into elbow straight position. Okay. With that, we can maintain this kind of posture. If the patient keep buckling, there's no point in this. Okay. You have to choose some other position. You have to get the control. So once imagine the patient has good control, they can be in their position. So what else we can do? One is static stability, maintaining this position. So maintain this. Can she maintain this position? What can happen? If this side is weak, she will always shift to that side. So what you have to do as help is you have to be always on the weak side. Every time during mat exercise, walking, standing, anything, you have to be in the weak side. So you never know anytime they just collapse. Okay? So there might be chance that they'll have asymmetry. You have to keep helping them to maintain that. So we ask them to keep pressure, put a pressure weight bearing on the hand, the leg, try to maintain without wobbling much, swaying much. We see how long they're able to maintain. 30 seconds. Then keep increasing that time. Okay. So imagine they achieve the static position. Then comes the dynamic. And all of you want to tell here is this is the first position where they start putting weight on the after hook line. The second position they position to start weight well. What are the benefits of this? The patient has like stroke, something like this. They have a tight spasticity in their plexus. This is the best position to maintain a stretch for a long period of time. It inhibits the spasticity. Very good. Even you saw the stroke patient, you have a flex posture like this. It will stretch, all the fingers get stretched well. So this is really good to lengthen the spastic muscle. Knee, what happens? In a stroke patient, usually they have hyperextension because the quadricep muscle is spastic, like just goes, be always tight. So this patient will stretch the quadricep, keeps in limitation, inhibits the spasticity. So just being in this position itself will bring a lot of benefit if you're dealing with a stroke patient. Will this avulsion help for spinal cord patient? No, not really. Because it's a permanent, if there is complete permanent damage of the lower limb, there's no point you can gain any strength in the bone. Parkinson's patient can help to get a good control on trunk. It's a very good trunk control exercise can be done, like such as cat and camel. You need to do cat and camel. Yeah, this is one. This is like that we can do to bring mobility in the trunk. Very good. For ankylosing spondylitis patient and many other patients. Very good. Now she'll maintain the position. So it depends on what is the purpose of your quadricep position. Now, let's finish. We have done the getting into this position. Stability, static stability is done. How do you do a dynamic stability? For dynamic, as you know, first is weight shift. Okay, she shifts the weight. It's very small weight shift. We need to see whether they can control this. Okay, you can use this as a repetition. You can do 10 repetition and do 30-second break, 10 repetition, and 3 sets can be done as a part of your any other exercise. So once she does forward backward weight shift, you can do sideway weight shift. It's a little more difficult. So what you are going to do is you're going to put hand over the pelvic to control. Okay. Once she does this, imagine she's able to really shift well without losing balance, able to maintain. Then we can slightly maybe expect the patient to lift one hand. You can lift the bad hand first because good hand can support more, and then come back. So see how she maintains the balance. So I'll go to that side to see. I'm supposed to be on the weak side right now just to show on the weak side. And then once you get her again, you can ask her to do that. So always do this on the weak side can be lifted. Once you think later on maybe you can do the good side. But you need to be very careful, you might feel that. So you have to have a control over the pelvic and the step. So once she gets a good control of the hand, you can do alternate. One hand and the other. Slightly. Then you can come back for a brief period of time. Then you can keep doing it for a long time. Okay? So that will be alternate arm shift. And co-contraction can be done. How do you do co-contractions? Like, once you achieve very good dynamic support, I hold this. Okay, I give her adduction force. So I want her to maintain that. Exactly. See if she's abducting. Now I'm abduction force, she's abducting. This is a co-contraction. So I keep doing that, she's maintaining strength. She's trying to maintain by isometric contraction. Same thing we can do for the leg. So I'm trying to push the leg forward. She's trying to push against me. So it's isometric. So I'm pushing backwards, she's pushing forward. So this can be done as a co-contraction. Very good. You can see that she's contracting. So this will help for a joint approximation and also for good balance. So that can be done. Okay, so now we're going to go for the sitting position. Okay. If you want to put, now from here if you want to go for sitting, you can go for sitting. What we do is, we ask them to walk backward and then go for knee sitting. Okay. From knee sitting, they keep the hand at the side, any one side, maybe that side. Okay. From side sitting, then she will elongate her legs and then grab it. So from like this you can put the long sitting. Then from here you can do a lot of active sitting. So we just show another way how to do a long sitting. Okay, imagine you're talking about paraplegic patient. So you don't want to go for quadruped and from quadruped you want to do sitting. Then from supine you can do a sitting. Therapist will put the shoulder leg up and what you're going to give you pressure. This is how you can come to long sitting. So you give pressure like this. Then you should do the shifting. Then do like this. With the one hand. Then 1, 2, 3. Then you pause. There's also okay. If you want for the position, go from supine to long sitting. Okay. Okay. The next will be kneeling. So we'll do from quadruped to kneeling. So for quadruped, there are two options. You can go for sitting and kneeling sitting, long sitting activity, or you can get the patient on kneeling position. So how do you get the patient going? So ask the patient to walk backward. Like this. So while she's in that position, I will be in front and slowly ask the patient to walk to the thigh. Okay? And she can, if she wants, she can keep her support of the spine, shoulder, or you can keep a table lifting. And you be with the patient. With the patient, you stand. So I'm just lifting her pelvic so that she stands. You go with the patient. With this, initially you can keep wide base of support. Keep the wide base of support. That's more stable. Later on, then reduce the base of support. Slightly reduce the base of support. Do this. So this will be a progression. And once without with support,
Sorry, 1 minute. It's lagging just because of internet. So maybe in the gap, like let me show you the other video, the fast video. So in the quadripone activities, you can do movements like this. Okay, so maybe in this video, or like you would have seen, like it's looking very easy and looking very fast.
Chair sitting to standing
Another
position.
video.
Therapist and patient ના બંને પગને આ રીતે
This
stable
is like
પરિસ્થિતિ
from
પર
chair,
standing
how
ઉપર
you are
આવી
going to
નાખે.
make them to
પછી
high
બંને
sitting.
hand,
Sorry, from
therapist ના hand
chair,
પર
that is from high sitting, how you are going to make the patient to stand. So this is called high sitting position. So this can be like either from the bed, you can make the person to come to side lying, then sitting in the side of the bed. Okay, so from that also you can make
therapist
them
અને
to
patient ના
stand.
બંને પગને આ રીતે stable કરશે જેથી પગ standing વખતે હલી ના થાય. પછી બંને hand therapist ના hand પર મુકાવવાના અને pelvis થી lift કરવાના. જો heavy patient હોય તો બીજા therapist અથવા તો patient ના relative પાછળથી pelvis થી patient ને પકડી અને lift કરવાનું. For hemiplegic patient. Hemiplegia એટલે કોઈ એક સાઈડનું અપર લિમ્બ અને લોઅર લિમ્બ બંનેનું પેરાલિસિસ. ફોર એક્ઝામ્પલ, the right side in this patient, the right side અપર લિમ્બ અને લોઅર લિમ્બ બંનેનું પેરાલિસિસ છે. તો પહેલા આપણે કહીશું રોલિંગ. તો રોલિંગમાં આવશે supine to sideline and sideline to prone. તો પહેલા supine to sideline. તેના માટે જે રાઈટ સાઈડ અફેક્ટેડ છે એના અપર લિમ્બને આગળ મૂકી દેવાનો. પછી જે આ ઓપોઝિટ સાઈડ નો હેન્ડ છે એનાથી પ્લિન્થને હોલ્ડ કરવાની એન્ડ જે ઓપોઝિટ સાઈડ નો જે લેગ છે એને ક્રોસ કરી દેવાનું. પછી પેશન્ટને પેલ્વિસ અને શોલ્ડર થી પુશ કરવાનું. આ જે સાઈડ લાઈન સુપાઇન ટુ સાઈડ લાઈન અને એ જ સાઈડ લાઈનમાં પછી બસ આગળ જો જાતે જાય તો ઠીક છે, નહીં તો પછી સપોર્ટ આપીને પ્રોનમાં લઈ જવાનું. આ તો સુપાઇન ટુ સાઈડ લાઈન એન્ડ સાઈડ લાઈન ટુ પ્રોન. સ્ટાર્ટ. હવે પ્રોન ટુ સાઈડ લાઈન અને સાઈડ લાઈન ટુ સુપાઇન. તો પહેલા જે અફેક્ટેડ લિમ્બ છે એને અપર લિમ્બને આગળ મૂકી દેવાનો અને જે આ નોન અફેક્ટેડ લિમ્બ છે એને અહીંયા આ રીતે રાખવાનો અને પેશન્ટને અહીંયાથી પુશ કરીને ઉપર થવાનું કહેવાનું. જે લોઅર લિમ્બ છે એને ક્રોસ કરાવી દેવાનો. પછી શોલ્ડર અને પેલ્વિસ થી પેશન્ટને લિફ્ટ કરવાનો. આ થયું પ્રોન ટુ સાઈડ લાઈન અને એ જ પછી આગળ જાય અને પ્રોન ટુ સુપાઇન. Mat exercise for prone on elbow, to prone on hand, to prone kneeling, to kneeling, kneeling to half kneeling and half kneeling to standing. તો એના માટે પહેલા પેશન્ટના બંને હાથ શોલ્ડર જોડે લઈ દેવાના. પેશન્ટને પછી સપોર્ટથી ઉપર કરવાનો એન્ડ એલ્બોને શોલ્ડર નીચે રાખવાનો બંને સાઈડ. બસ આ પોઝિશન થઈ prone on hand. Sorry, prone on elbow. હવે આવશે prone on hand. તો પેશન્ટને સપોર્ટ કરવાનું, હેન્ડને શોલ્ડર નીચે લાવવાના બંને સાઈડ અને પછી પેશન્ટની બેકને લિફ્ટ કરવાનું. આ પોઝિશન થઈ prone on hand. હવે એના પછીની આવશે prone kneeling. એના માટે પેશન્ટના જે છે ની એને સ્ટેબલ કરવાના, પેલ્વિસથી પેશન્ટને લિફ્ટ કરવાનું એન્ડ પછી સપોર્ટ આપીને બંને હેન્ડને શોલ્ડરની નીચે લઈ જવાના. આ પોઝિશન થશે prone kneeling. After prone kneeling, there is a kneeling position. For kneeling position, પેશન્ટના હેન્ડને થેરાપિસ્ટના હેન્ડ પર મૂકીને પેશન્ટને લિફ્ટ કરવાનું. આ થશે kneeling. kneelingમાંથી આવશે kneeling position. kneelingમાંથી હાફ kneeling અને standing. For the half kneeling, પેશન્ટનો બંને હેન્ડ થેરાપિસ્ટના હેન્ડ પર મૂકવાના અને એક પગ છે એને આગળ લાવવાનો. આ થયું હાફ kneeling પોઝિશન. હાફ kneelingમાંથી સ્ટેન્ડિંગ પોઝિશન. સ્ટેન્ડિંગ માટે જે પેશન્ટનો લેગ હશે એનો ઓપોઝિટ લેગ થેરાપિસ્ટનો આગળ કરવાનો અને થેરાપિસ્ટ પેશન્ટના પેલ્વિસને લિફ્ટ કરી ઉપર કરશે. આ થશે સ્ટેન્ડિંગ. હવે સુપાઇનથી સાઈડ લાઈનથી એલ્બો સાઈડ લાઈનથી સાઈડ સિટિંગથી લોંગ સિટિંગ. ઓકે, એના માટે હાથ ઉપર કરવાનો, લેગ બેન્ડ કરીને લિફ્ટ કરીને સાઈડ સિટિંગ. હવે સાઈડ સિટિંગમાંથી સાઈડ લાઈનમાંથી એલ્બો સાઈડ લાઈન. તો આ પેશન્ટ છે અહીંયા પેશન્ટ પુશ કરશે અને થેરાપિસ્ટ લોકોને આસિસ્ટ કરીને લિફ્ટ કરશે અને એલ્બો આ રીતે છે એલ્બો સાઇડ લાઇન. એલ્બો સાઇડ લાઇનમાં સાઇડ સીટિંગ તો બંને ની ફ્લેક્સ કરવાનો, ની ફ્લેક્સ કરીને જે આહાર છે એનાથી પુશ કરી લિફ્ટ કરવાનો અને બંને હેન્ડ આગળ લઈ જવાનો. યસ બસ આ છે એલ્બો સાઇડ લાઇન, સોરી સાઇડ સીટિંગ. અને સાઇડ સીટિંગમાંથી બંને પગ છે એ લિફ્ટ કરીને આગળ મૂકી દેવાના. તો આ થશે લોંગ સીટિંગ. સાઇડ સીટિંગમાંથી પ્રોન નીલિંગ પોઝિશન. તેના માટે બંને આ રીતે પોસ્ટ આગળ થોડા પ્લેસ કરાવવાના, પછી છે ને પેલ્વિસથી લિફ્ટ કરાવી બંને ની પોઝિશનમાં થઈ જવાના. બસ આ થશે સાઇડ સીટિંગમાંથી પ્રોન નીલિંગ પોઝિશન. હવે પ્રોન નીલિંગમાંથી બીજી જે આગળની પોઝિશન છે એ આગળના પ્રમાણે કન્ટિન્યુ ચાલે.
Okay. So,
For the changing the position, one sitting to another sitting, like plane sitting to a chair sitting or toilet sitting. So, एक handle છે એને પકડો, push કરી અને આ રીતે lift.
okay. So in this video, if you see, like you saw the various ways of bringing the patient. So depending on the functional activity you are planning to train the patient. So according to that functional activity, you need to plan which way you want to bring the patient. So either you want to bring the patient from supine lying to prone, then prone to quadriprone like that, or you want to bring from directly from supine, or you want to bring from supine to side lying and side sitting like that. So depending on the functional activity plus depending on the patient's ability of the limb, you need to decide the sequence of the movement. Is that clear? So the actual movement, if you see, like from the supine lying till like prone on elbows, prone on knees, then quadripode, then side sitting, then kneeling, half leaning, standing. So that will be the actual sequence. But you can modify according to your need and according to the other functional activities you needed. So maybe suddenly the patient needs to go for side sitting. So you want to train the patient first about side sitting, then you can go for that. So depending on the need you can modify and you can go, or like you can decide the pathway or the sequence which you want to follow. Okay, I think that other video has downloaded. Okay, it's very poor.
And Kurt is going to
So now we're going to go for the hook line position. So it's spine position and knee bend. Okay, so imagine patients completely supine. They have no control.
Hook lying, already we have seen it, right?
Another option with the kneeling, half kneeling is, imagine you want to do the proper hip strategy. You can put this is dynamic control, hip strategy. Put the weight on the gym wall and move forward. Back. This will also help the core muscle to get activated. So this is a very good activity. This will also strengthen the resetting control of the hamstring.
One minute, let me check with other internet connection.
Another option in the kneeling, half kneeling is, imagine you want to do the proper hip strategy. You can put this dynamic control hip strategy, put the weight on the gym ball, can move forward, back. This will also help the core muscle to get activated. So it's a very good activity. This will also strengthen the resetting control of the hamstring. So this is an advanced skill that can be achieved in any position. If it's a half kneeling position, also same. When you do this, what happens is from this leg, the weight will transfer to this leg. So it can help to create that kneeling to, kneeling to stand. It can help for that. So from half kneeling, if you want to go for standing also, you can start in this position. So there will be therapist standing behind, trying to lift the pelvic up as the patient does this. Okay, then you can change position. So it is a quite advanced one. And in the sitting, a lot of things that can be done in sitting. So balance training. So if they want to do balance training, sitting activity. After firm surface, they want to get into soft surface. This can be done. In this also, we can keep wide base of support initially, then go for reduced base of support. First will be supported sitting, then unsupported sitting, then close eye, do the activity, open eye, do the activity. So shifting, pelvic tilt, reaching activity, reaching beyond the basic support, throwing and catching activity. Thank you.
Okay, a last video, okay, just stay for another 10 more minutes. We'll complete this particular topic today. You see whether it is getting open or not.
And then we'll see how she maintains it. So imagine if one side is weak, if this side is weak, I have to always be on that side. One hand at the shoulder, one hand at the pelvis like this. I have to get the weak side. So imagine she gets the, we have to keep doing this one on and off. So let's go again. Go back to sitting. So we have to get this position so that she can do independently. Okay. Imagine she gets she's able to do her stuff, she's able to do without much support, then it will maintain the static stability of this position. So static stability, like any other position, maintain the position first in this position. Let's say 30 seconds or more. So I don't want her to do more of swaying. So if she's doing swaying, I have to hold on to support her. Keep telling her, keep upright, tall, keep yourself tall, keep yourself tall, like as if something's pulling your neck, try to be tall. So eventually she will develop the stability. Once she gets the stability, with a smaller base of support, you can, if you want, with the eye closed, same stability can be maintained. Once you get the static stability, then the next is the dynamic control. Dynamic control, shifting, side to side. So that's the first thing, forward and backward. So it takes time, like don't just suddenly jump into it, like it takes time to do that. Shifts it. Once the patient is able to shift, then like any other earlier one, maybe you can ask her to turn the trunk, that's dynamic as well, into this side. Very good, without turning the trunk, just a neck, neutral, switch, go back, neutral position. Then maybe just a trunk, neutral position, trunk, neutral position. This is all within the base of the support. And she even, now slightly she'll be able to, I have to be always with her, I cannot just go away because she might fall anytime. So me maybe touching the hand like this. So this is within the base of support. You can do multi-direction or one direction. Or you can ask her to hold this and you can give it to me. I can get this active. Now we want to do it beyond the base of support. Then challenge the far away. Or just first ask her to touch him. So can you see she'll be bending to do this away from the base of support. More challenging. So this hand, right, left hand out. Right. The left hand out. So it's a multi-direction. Again, if she's able to maintain this for a long time, and we know that out of base of support she can do, and I can do a lot of catching. Throwing activity. Yeah, very good. But I still advise someone to be there always beside her and put a gate belt when you're doing that, so that you don't. Balance is something anytime they can fall. You never know. Safety is very important. So then you can ask her to hold, reach up also. Yes, and then she can just pick it, keep it on the ground. Yes, there are a lot of things that we can do. Pick it from down. Very good. So when she is doing that, you can see hip strategies get activated. So that is where we start developing the balance. So dynamic is done. Then if you want the skills, you can like fine skills, counting the pebbles, or maybe writing on a board, something like that can be done. That's a skill. Okay. So from here we go to the, imagine if she's successful in this, then next is the half line, half kneeling position. So for this you can slowly ask the patient to bring or shift. Actually they have to do the shifting. But they have to shift on the side that they are not lifting, and then they have to bring exactly, and lift this exactly. So here, the leg which is down will get more pressure than the leg which is in the front. So this has to be done. Imagine this is weak side, that is strong. So always keep the leg behind, which is strong, so that it can support the balance. So weak will be front. Later on, you can change. You have to change. You cannot always be in this position. You have to alternate. So imagine this will be difficult. So she has to again go back, knee to the kneeling, again shift and bring it front. So you have to keep doing this several times till she gets the good control over this position. She's able to get into this position. Once she gets into this position independently, start with a static, same like your kneeling position. So with the support, I can just support belly, and then see how long she's able to maintain this. 30 seconds, and then go on using the time, and then initially with support, and then without support. Okay, then now imagine you've got the support, so you go into this. So yeah, so we wind up here.
Okay, so maybe like on seeing the videos, you may feel like it is very easy or it may be like very tough. But don't see the video continuously. What you do is you see a sequence, then practice that particular sequence, then go for the next, so that it will be easy for you to practice. And keep in mind the position, the holding, everything is important for OSPE. So when when you are practicing for the clinicals, it is totally different. But when you are practicing for OSPE, the examiners will be seeing where you are holding the hand, how you are holding the hand, and what instructions you are going to give. Is that clear? So tomorrow we will be having the tutorials of all the chapters whichever so far we have seen. If we are not able to complete tomorrow, then we will continue on Friday too. So by this week, like we will be completing all the chapters which we have already covered for the mid semester. Is that clear? So what I want to know was, like, at least before your tutorial class, I want you to read at least the slides so that you can clear your doubts. Is that clear? So at least go through the slides and write down your doubts so that we can clear it tomorrow. Is that clear, everybody? Okay. So far, up to today's videos, everything I have uploaded in LMS. Only pending is like class recording, so that I will be doing it by today or tomorrow. I will upload the class recordings. Is that clear? So remaining everything I have uploaded, you can check. If anything is missing, please let me know. Then I will do the needful. Is that clear?
Yeah, okay, Miss.
Okay. So thank you. Can we end the session?
Yes, Miss.
Yes, Miss.
Thank you.
Thank you, Miss.